Okay. Good morning, everybody. Today we have Dr. Katie Hootman. She's a registered dietitian-nutritionist and a director of the Nutrition and Metabolic Research Core at Weill Cornell Medicine's Clinical and Translational Science Center. Dr. Hootman directs the operation of the CTSC Metabolic Kitchen to provide specially designed diets and nutritional formulas for research. She counsels and educates patients per protocol and provides training in dietary assessment and data collection methods to research teams. She also conducts body composition assessments, implements indirect calorimetry, measures anthropometry, and uses software for menu design and nutritional analysis of recorded dietary intake. She offers expertise on human nutrition and diet, research design and methodology, and collaborates with clinical investigators who engage the resources of the CTSC. Dr. Hoopman also serves as a preceptor and mentor for students in graduate and professional programs. Dr. Hoopman is passionate about advancing what is understood and about how different foods and eating patterns can improve the health of individuals and communities.
Well, thank you. Thank you for such a kind introduction. It's a pleasure to be with you all today, and I'm happy to be able to discuss the CTSC Nutrition and Metabolic Research Core and our team and our activities. So how about I share my screen and we can get started?
Yes.
All right. All right, can everybody see the starting screen, Nutrition and Metabolic Research?
Yes.
All right, wonderful. So we'll also discuss, in addition to our core and our activities, some of the video content that you reviewed before class. I really think that there are some good concepts in those videos, and so we'll talk a bit about the social determinants of health and health disparities. And Agnes will let me know if there are any questions that come up in the chat, and she'll also make sure that we're running on time toward the end. So let's begin. First, we will review some concepts from the digital content you watched for class today. So social determinants of health and minority health disparities are really complex and rich disciplines. They're entire disciplines, and we'll really just scratch the surface in our short time together today to discuss some basic concepts and some evident examples. We will move into a deeper dive into information about nutrition research and the variety of activities of the CTSC Nutrition and Metabolic Research Core, and then we'll wrap up with a few questions for discussion, and we'll have an opportunity to discuss any topics that are of interest to you all. In the animated video by Let's Learn Public Health, social determinants of health were defined as the conditions in which people are born, grow, live, and age. These factors have a large influence on our health. It also determines health inequities, which are the unfair and unavoidable health differences between different groups of people. This video explores the social determinants of health and offers a useful framework to understand these factors. I really liked this video because animated videos are often fun to watch, but I think that the voiceover did a great job of explaining how characteristics and life circumstances interconnect to impact personal health as well as public health. So let's dive in. The animators depicted the World Health Organization framework for conceptualizing social determinants of health using this diagram. And they broke it down into two basic categories of determinants, or the structural determinants and then the intermediary determinants. So among the structural determinants, we saw socioeconomic and political context. This could be the type of governments a community has, or types of policies, or it could be the values of the culture of that community or the individual. We also saw socioeconomic position determinants. That includes education, occupation, as well as other demographic factors or characteristics. And one thing that's really important to note is that the terms in this diagram, these variables, are actually very complex. Each of these variables packs in a lot of information about a person or a group or a community that has these characteristics. And so these words are important because they actually tell us about maybe how active somebody is, or like occupation, for example, might tell us about, or might indicate or suggest whether somebody has a lot of physical activity, maybe if they have a manual labor occupation or job, or maybe if their job is sedentary, or if they're out of work, that might be something else that we can use to fill in more information of what we can understand about individuals as well as communities. Also, we see in these intermediate determinants, oh, I realize I'm moving my mouse on my other screen, but not on this screen. So if we look at the intermediary determinants here, this includes material circumstances, that might include housing and access to resources, as well as psychological and psychosocial factors, and certain behaviors. What are our lifestyle behaviors? What do we choose to do? How do we behave? What kind of choices do we make for ourselves? As well as biological factors, things that are inherent to our biology or our physical health. And as you can see, this is a pretty complicated graphic that has, like I said, complex contextual terms in here, but you also see arrows that lead from one thing to another, and there are bidirectional arrows. And so really understanding social determinants of health takes in mind that to look at this as a web of interconnected factors. So looking at this diagram, where do you think what someone eats or their usual diet would fit in to this diagram? Which kind of factor or which kind of determinant of health do you think that usual diet would fit on? And I welcome anyone to jump in with an idea. Any takers? All right. If not, we will just proceed. So usually, so dietary factors, they can affect our physical health and can interact with our biological factors, but really it's our behavior. We usually put diet and our dietary choices into the behavior type of determinant of health. And so that would be in this intermediary determinant box. I would have loved to see this video go a little bit further into nutritional determinants of health, and as well as eating behaviors and how that interplays, because we can see how, either an individual or a family or a community's dietary practices can also relate to education, occupation, income, social cohesion, and social capital as well as these other intermediary determinants. So the COVID-19 pandemic has dramatically affected dietary choices for many people, and food security is one of those factors. It's a determinant of health that is related to socioeconomic factors as well as physical well-being. Food security refers to how reliably a person or a family, a household, or a community is able to access adequate amounts of nutritious food. And this recent report and graph from the Brookings Institute shows the rates of food insecurity among households and households with children. And what we can see here is that the rate or the proportion of households with food insecurity almost about doubled since before the pandemic. It's also noteworthy that the proportion of children with very low food security has also more than doubled since 2018. And for reference, what does food insecurity mean? Well, in this study, households were surveyed, and households were considered food insecure if they responded often true or sometimes true to the following statements. The first statement was, the food we bought just didn't last and we didn't have enough money to get more. And the second statement was, the children in my household were not eating enough food because we just couldn't afford enough food. And so if respondents to this survey responded often true or sometimes true to those statements, then they were considered food insecure and added to the data in these lines here. we can move on to discussing Michelle's story. So this was one of the assigned videos for a head of class, and I really liked this story for multiple reasons, which we'll discuss. And feel free to chime in anytime if anybody else had impressions or something memorable about this that you liked or were interested in. So Michelle Simmons is a patient, a mother, grandmother, and she's active in her community. And she had family members with diabetes and heart disease, including her mother, who actually succumbed to heart disease. And in her story, she talked about how she likes to make healthy meals with her family, and that habit of making healthy meals together really started when her daughter went to college and came back with a different, healthier diet. Now, and Michelle discusses that she didn't eat a healthful diet her entire life. In fact, when her daughter came back with these new dietary habits and new ideas about really, what is health worth, and diet and healthy behaviors, um, that was new information to Michelle. And what I really respect and love about Michelle's story is that instead of pushing against change, Michelle was able and willing to try it. And from that she was able to build healthier habits that also strengthened her relationships with her family. That's really compelling. Seeing people who have an open mind and are able to make change that improves their life and the lives of those around them. I think it's important to have an open mind to take in new information. And her example of having the humility to take an honest look at her own behavior and say, hey, maybe what I'm doing or what I've been doing isn't really the best for my health, and here's something else I could try to improve. Especially when a family member, her family member in this case, was also making those changes, I think is really compelling. It's a great example. She also commented that she had been accustomed to eating fattier foods or foods in different ways that might not be supporting the best health for her, especially as she saw her elders get sick and die. And her open mind and willingness to build these new habits, both for her health and for her family, was really inspiring, at least to me. And her story also shows how cultural practices around food can be held up to the light. And individuals can choose for themselves whether the practices they are accustomed to doing are really in their best interest, or whether they might try something else. Individuals can choose for themselves when they look at their own behaviors, whether they want to keep doing what they've been doing or try something new to get a healthier outcome. And that's really empowering. That's really empowering. I think that's actually pretty important for all of us, not just for Michelle, or not just for individuals who are facing health crises. I think it's important for all of us to be able to look at our own health and our habits and practices and hold them up to the light and ask whether what we're doing is helping us get closer to what we want or not. Think about it, examine our habits, and ask, like, is this helping me live well? Is this helping me to thrive? Is this behavior or habit helping me to connect with my family or with my community? And being able to be honest with ourselves and also willing to take action with those answers.
Miss Jones has her hand raised.
Yes.
Oh, yes. So yeah, I was very moved by the story as well. And, just the fact that she can acknowledge that, yeah, she had to make changes, and her daughter was a very big influence, and uneducated, college educated, so there was a different perspective. So that was good. And also, and that she was willing to make that change, given what happened to her mother and perhaps people around her who had poor eating habits. And then she also wanted to take her story and work in a community. She joined the community advisory board and is helping others. So I think that's all good. And also, one last thing is her religion was a very important part of her life too. I could tell that. So that's a very important piece as well.
I agree. Those are fantastic points. Like, Michelle's story it's a rich, complete story with all these facets of life that make what we're doing meaningful. I think exactly her example was fantastic, as well as I'm so glad that you pointed this out, that she joined the academic advisory board at the academic medical center in her city. Like, this is a direct way that she can contribute her own point of view to and guide their activities to benefit individuals as well as her community. She's really a go-getter and a great example for making healthy changes. So thank you, Ms. Jones.
You're welcome.
So another video discussed the different phases of clinical research. And actually a few weeks ago, Barbara Horman discussed these phases with you. So I will not go into depth, but this speaks to the central nature of translational science. So this video discussed the different phases of development that it takes to bring drugs, devices, or new diagnostics from an experimental idea to a useful, marketable intervention or technique. And each of these phases is successive, and each phase provides a stronger level of evidence that the new drug or device or diagnostic approach works as well as intended, or works as intended and is reasonably safe. And this adage here, from bench to bedside, has been part of the National Institutes of Health programmatic emphasis to streamline the translational discoveries made in labs into effective and innovative therapies for patients and populations. From bench to bedside and back again has been a paradigm of translational science that has now forged a couple of generations of scientists and researchers that share that same aim. This initiative or this directive for translational science has also helped create interdisciplinary research enterprises like the CTSC to identify and support the best, most promising projects and professionals in science across health disciplines, and in different settings and in different applications. So this from bench to bedside and back again is really this this adage and emphasis behind a whole host of research programming and training. As the director of the Nutrition and Metabolic Research Corps, our research is usually testing different dietary formulas or nutrients and dietary interventions on nutrition-related outcomes and behaviors, and rather than with newly developed drugs. And so this aspect makes our research in nutrition generally safer than drug trials because we are working with food and diet, and this type of research is also more accessible to a broader range of researchers and across disciplines, because nutrition is an underlying factor in all patients' lives and in all clinical research. The nutritional status of the subjects can be really central to the outcome or the effects when what happens in the study. But before we proceed with studies where we're testing the effect of a full-scale experimental diet in patients or volunteers, even healthy volunteers, participants, the components of dietary interventions are often tested in a bench laboratory in cells or in vitro, as well as in animal models. And these preliminary studies need to yield favorable results in order to move forward with it in human research. These initial in vitro and animal studies are very important steps because these studies often show the proof of concept that the hypothesized effect of a dietary intervention or its components will probably, will have that effect in the next system. Also, a benefit of working in dietary research is that we can often find real-world data of nutrient intakes and eating patterns that are already evident in humans. And this can support new ideas of how we can better understand nutrition and how nutrition can actually be an active agent in health, or how nutrition can be an active agent in the recovery of illness to promote health in individuals as well as populations. So the Clinical and Translational Science Center is committed to advancing medicine, and the health of individuals, families, and communities. Each of the gears in this graphic reflect a team that is dedicated to working collaboratively with the other teams to create and test and develop and implement innovations to improve health outcomes. The CTSC seeks and supports creative, promising research across a wide variety of disciplines, including cancer and oncology medicine, metabolic diseases such as diabetes, and cardiovascular disease. The CTSC also seeks to support innovation in other fields that are completely separate from medicine or different, such as engineering, software development, includes genomic science, infectious disease and vaccine development, which is a bit related to medicine, as well as the opioid crisis and more. So the Nutrition and Metabolic Research Core is a team and a set of resources within the clinical and translational resource unit. So let's move on to our team and what we do. Great. So at the top of the screen, there's a good description of what our core does. So the Nutrition and Metabolic Research Core, what we do is we collaborate with physicians and scientists to provide services for clinical research that are related to diet, nutrition, and indicators of metabolism, such as body composition and metabolic rate. We also take a lot of pride in our educational outreach because we train students, fellows, interns, and colleagues, in the methods and the practice of nutrition and metabolic research. Like, how do we conduct rigorous, cutting-edge studies? How do we be able to answer some really compelling questions to improve health of individuals, as I've said before, and as well as communities, families. So in our work, we work directly with patients for the most part. In clinical research, the study subjects tend to be patients. And so those are our primary, subjects that we have and serve. So actually, let's talk about nutrition research, because I think it's helpful to have some concrete examples that show kind of what this field is, what's in it, maybe what's not, what's under the research umbrella. And I think first it's important to look at, what is research? What is that? What does that mean? And it's really the systematic study to determine new facts and create new knowledge, to discover new knowledge, new truths that we didn't know were true before. And I think when I learned this in my training, I thought that was really exciting. That's right. Research is meant to test something that we don't know for sure how one thing affects another. We have a pretty good idea based on the preliminary research we do, maybe the bench science that we do or in animal models, but in humans, we really want to bring forth new knowledge about how we can improve health, and especially using food, nutrition, and diet. So I think having that concept of what research is an exciting place to start. So then going on to what is nutrition? What counts as nutrition research? And nutrition is actually quite broad if you think about it. Firstly, it can be food and diet. So research that includes food composition studies. So this is looking at, what are the micronutrients as well as the macronutrients in certain foods. So macronutrients would be like carbohydrate, protein, fat that are in a food, and micronutrients are things like vitamins and minerals. And so food composition research is really looking at different foods, say, potato, a certain variety of potato, and then determining what is the nutrient composition of that food and what are all the variations of the nutrient composition of such a food. Like if it's grown in different parts of the country or different parts of the world, does that same food have a different nutrient profile based on that? And so food composition research is actually a very large area of nutrition research, because there are obviously so many different kinds of foods. Research pertaining to diet also includes patterns of dietary intake and eating behaviors. This is really important in public health nutrition, and we see this from observational studies, which we'll discuss in a short bit, about what are people eating and what are their health metrics as we observe kind of populations and survey populations and groups of people to see this evidence of what are people eating, how are they eating it, and what's their health like. So nutrition research is also the research into nutrients, looking at the micro and macronutrients. What are the sources of these nutrients? How are they absorbed? How are different nutrients metabolized? And how can we come up with different conditions? If people eat certain foods at certain times in certain ways, does that change how the nutrients are absorbed? Does it change the nutrient content? Does it change how those nutrients can be used in the body? So that's also an important area of research. Also, there are interactions. Why, do some people or groups digest different foods foods differently from other groups or people? Why is that? Are certain nutrients absorbed differently? Or if a combination of different foods or components of the diet are consumed together, do they interact? Like, does one food enhance the absorption of a vitamin or mineral from another food? An example of research that would identify that is if we have vitamin C and a high iron food in the same meal, the vitamin C, which comes from plants, can actually help us to take up and absorb more iron from the iron-rich foods in the meal. And so those nutrient interactions and food nutrient interactions are just a couple of the interactions that we might investigate. Other interactions include drug nutrient interactions, and so this is something that a lot of people, a lot of the population who's on medication sometime in their life is told to avoid certain foods or to eat more of certain foods because of the medication that they're on. That would reflect a drug nutrient interaction or a drug food interaction. So that's also a large area of research. So nutrition research can also be about nourishment, about what is the nutritional status of individuals or groups. This includes study of malnutrition, of hunger, of food insecurity. We saw the graph of results of a study on food insecurity earlier in the talk. So this also can be to study clinical signs and symptoms of nutritional deficiencies. So if a person doesn't get enough of a certain nutrient, we'll take vitamin C, for example, what are the clinical signs and symptoms of that nutritional deficiency? And lack of vitamin C leads to a condition called scurvy. And so we can look at the clinical signs in that, which can be bleeding gums, for example, because vitamin C is really important in building and having proper tissue development and wound healing. And so that's another area of research, is looking at the clinical signs and relating that to nutritional deficiencies or malnutrition. So as you can see here, these are concrete examples of what counts as nutrition research, and it shows really how broad the field is, what's all under the nutrition research umbrella, and really how much potential there is in this field, in this practice. And there are more areas, more concrete examples as well, but in the interest of time, we'll move on. So every study starts with a compelling unanswered question. And this is the research question, which drives the study design, data collection, and analysis. So the research question is the point of doing any study. It's the point that you want to answer, the point of doing the research. And it's important to keep this in mind, especially when you hear headlines about research, because often great studies are designed and carried out to answer one very narrowly defined specific research question. And especially when it comes to nutrition and information from different scientific studies, often headlines will say something about data from a study, especially when it's related to nutrition. And the headline might be about whether a food or a nutrient is good for people or otherwise. And the research study might not have even been designed to answer that question about that certain nutrient or that the headline is talking about. It's unfortunate that this happens actually quite a bit, especially with nutrition studies, because there's such a strong interest in nutrition because everybody eats and everybody ends up talking about food with people in their lives at some point, and so headlines know that people are very interested in this, but unfortunately that leads to a misrepresentation of science oftentimes, because headlines are sensational, and oftentimes research studies are designed to answer a very narrow question that might not have anything to do with nutrition or diet, or even if they are designed to answer the specific a specific diet related question, oftentimes headlines can take related data from the study and kind of make it more sensational than the science really would support. So it's just good to keep that in mind, that the research question is the starting point for all studies. We need a compelling question, right, to move forward, because research studies, as you learned from previous presentations here in this course, like, it takes a long time to plan research. There are a lot of moving parts and a lot of people involved to get studies planned and approved and implemented and rolling, right, so that we can drive discovery. The research question, it's a starting point, and it's really, what are we studying and why? Why is this important for us to study? How are we going to study it? What are we going to measure? Also, how are we going to analyze the data that we collect? And how are we going to report it out so that we can actually answer this compelling question that started it all? And there are two studies in terms of like types of studies. There are two categories of studies generally. These aren't the only types of studies out there, but these are two key types of studies in nutrition research, as there are observational studies and intervention studies. And observational studies are appropriately named because these studies make observations and measurements in individuals and groups of people without requiring those subjects to make changes. They're not proposing an intervention or asking them to do anything different. Observational studies really just follow people forward in time and measure or survey them, and to gather data about their health, about their characteristics, their lifestyle, about their behaviors. And from that, we can get information on how people are living and how their choices actually connect to their health outcomes. The next type of study are intervention studies, and this is also appropriately named because intervention studies are where the research is actually implementing or requiring an intervention or a change in the people or in the subjects of the study, whether that's animal studies or in humans, right? The intervention study has enrolls subjects in the study and then performs the intervention usually on half the group or a portion of the group, and then keeps a portion of the subjects who don't get the intervention. Or maybe they get, if there's an innovation, say in a technique or treatment, maybe the intervention group will get a new and improved version of the treatment or the technique, and then the comparator group, the comparison folks will get the usual or standard care or the usual treatment. And so the intervention studies are important because it's definitely implementing and testing something new, and it's important to have the groups of comparison properly designed in those studies so that we can really answer a research question. Does this new and improved technique or method or intervention, does this really is this an improvement over what we usually do or the status quo? Something about observational studies and intervention studies and how they relate is, since observational studies are observing, right, they're seeing what people are already doing, especially in nutrition research, it's how people are already eating and living. These are really hypothesis generating studies, and the hypothesis drives the intervention study, right? So the research question underlies both of them, but from observational studies, we can make hypotheses around which we can design interventions. Like if we hypothesize that a plant-based diet reduces cardiovascular disease, then that because say we observe that people in the population who tend to eat a more plant-based diet tend to have less cardiovascular disease. If we make that observation, then we might have the hypothesis that a plant-based diet is associated with improved cardiovascular health compared to a standard Western diet, right? That happens not to be too plant-based. And so from there, that hypothesis, we might be able to design an intervention study around that, where we test whether a plant-based diet, where requiring, the change to a plant-based diet actually does improve indicators of cardiovascular risk or not. And so these two types of studies are closely interrelated and are both very useful. So on to the Nutrition and Metabolic Research Core and some of the services that we provide. It's such a pleasure to be able to talk about what we do. And as I've mentioned, talking about the research question and how studies are designed is one of the services we offer is to help researchers in the design of their studies to properly measure nutritional factors, as well as administer nutritional factors or interventions in their diet. And this is really important because the planning of studies is critical to how well or how smoothly those studies are implemented. And so proper planning is super important.
I have a comment in the chat from Jazzy.
Yeah.
She has a question. You can just speak.
I am here. I just had to cut everything down. One moment, okay? I'll be right with you. All right. So my question is this: in terms of these, the nutrition and metabolic researching, have you ever researched people who have been on prescription drugs, like for 20, 25, 30, sometimes it's not even funny, even 40 years, like in terms of hypertension? Their hypertension is perfectly, they no longer have, I should say, hypertension, right? Is there some sort of, and I guess this would be, this could fit into the intervention research, where a person or a group of people who have been taking prescription drugs over like 30 years can be observed, and their diet will change based on the nutrition and research. So in other words, there's so many people who are on medication that does not need to be on medication and never really switched over, because automatically it's like prescription as soon as they run out. How can that chain be broken so that people could begin to eat food that is valuable to them, right? So some of these people, they pay a lot of insurance.
Mm-hmm.
And the money that they pay for insurance, however, it works out, if instead of the insurance going to pharmaceuticals, it could go towards food.
Right. Or seeing a dietitian. Absolutely.
Well, yeah, seeing a dietitian, but I'm talking about food because there's a serious need of food. There's a big food insecurity, issue and challenges that the U.S. has. So instead of these people who probably no longer need to be on those meds for hypertension and other things, if they could somehow, it could be researched as to how they could break away from that and begin to eat healthy food. That's why I say instead of the insurance money going towards insurance, it could go towards a better way of eating.
Absolutely.
And the food itself.
Yeah, you make some great points. That there are conditions such as high blood pressure, hypertension, that can be ameliorated or improved with diet instead of drugs, right? And there has been quite a bit of research in this, and the best diet, one of the best diets for doing this is called the DASH diet, and it's the DASH stands for Dietary Approach to Stopping Hypertension, right? There has been quite a bit of research in this area, and I think it boils down to so many factors, but really having the coverage for patients to see a registered dietitian is really important, right? So on the individual level, you made a really good point of people maybe being over medicated or on medications for a long time, where they may prefer to try a dietary intervention. And again, that all needs to be, that's on an individual basis, that needs to be overseen in a clinical care team that includes physicians, dietitians, and so that the health of the individual is really put first. But to another larger point is that we do have quite a bit of evidence of healthy dietary patterns, right? The Mediterranean diet is another example of a dietary pattern, or a pattern of putting certain foods and beverages together in a certain way with physical activity that does support healthy cardiovascular system, a healthy weight, which also reduces our risk for other chronic diseases, including cancer and metabolic disease. And so how we can get that to more people is a really important question that we need to be asking ourselves as individuals, but also that we need to be asking for our families and our communities, right? How do we get better food and better food and a better dietary pattern, or better, healthier habits, to ourselves and the people that we love and the people that we know and the people that we live with. And I think those are really good points, and it's a really complex issue. And the cost of food, you made the point that it's really, to get healthier food to people is a real one. And that comes to a social determinant of health and food security, of like reliable access to safe, nutritious food, is something that a lot of communities are facing, as well as individuals and households. Again, like, nutrition is at all levels, and I don't think there is just one straight answer to it, but really it comes down to policies, at the level of governance of, do we have policies that help us to afford healthy food? Do we have policies that help us to access healthy, nutritious food? The more of those we can get, I think the better off population health will be, as well as individual health. And as far as it's really an individual case-by-case basis, the interaction between diet and medication. And sometimes medication, especially for hypertension, right? Hypertension, cardiovascular disease that includes hypertension, is the #1 killer of adults in the US. And so sometimes a hypertensive drug is really the intervention that has the lowest barrier, right, to acceptance and adherence, where making dietary changes can be really challenging. We saw from Michelle's story in that video that she had her family involved. She's got her faith community involved. She's involved in spreading this message of having an open mind to be willing and able to change habits or try new things to improve health. That's that is a lot more activity and support that's needed to support those changes over a long period of time than maybe taking a pill for high blood pressure every day. And so that's why the combination of nutrition management, as well as pharmacology, as well as having drugs that really help to reduce the risk of disease, to reduce the risk of having a heart attack or a stroke, right? When those things can work together, that's how we can get, greater improvements in health for everyone. And so, yeah, I think, it's not that nutrition competes against drugs for chronic conditions. It's really that diet and medications or medical care should really work together to synergize and improve everybody's health even more than it's ever been able to be improved in the past, right? Before we knew all of these things about diet and before we had all these effective medications. So yeah, wow. I mean, your points just open up a ton of discussion, and it's really good. Your thoughts are definitely in the right place.
Thank you. I just have one more other comment, and I know you have to move on with your PowerPoint. The other thing is community. like you have a lot of different stores and different communities. I mean, everybody doesn't go to a corner store to get their food, but I do believe that in some urban areas that those stores that sit on the corner should be held accountable for the food that they have in their stores. Because the first thing that, let's say a mother or a father, and I hate to say it, a lot of times it's a single mother, she has like no time in her day. And she goes into that store and she's trying to get something for her children before they go to school. And oftentimes the first thing that is picked up is juice, that's kind of just like sugar juice, sometimes soda and cookies. If is there a way, because of you are a researcher, if there's a way that the research community and nutrition can work with these urban stores to have better choices for families.
Sure. So that's a really good point, and there is research in this area of really how to change the behavioral economics of the foods that people select to try to incentivize people to choose healthier foods, right? I must say though that especially like in those corner stores will have the food that people buy. And that's why it's really important to look at one's own choices of, okay, where I vote with my dollar, where am I going to use my dollar to show that I demand this product, right? And if there's demand for, juice and cookies, then there's going to be more juice and cookies. And I completely understand that the convenience of foods is so important, especially in single parent homes, but also in any sort of resource constraint. It's like we need convenience, or we need it to be easy, right? That barrier to having a healthier habit. And so, having an apple or a banana is almost just as fast as opening a bag of cookies, right? And so marketing healthier foods, so they're that at eye level for kids or and adults, so that their prices are competitive with more processed items. I think there are quite a few tactics that could improve the choices made at corner stores, like you pointed out. Yeah, that's a great point.
And that's not all people that go in there to grab the cookies, but there are a lot of people who do go in and get proper food. But then it's like as soon as you go in, the design of the store is like designed for sugar.
Right, right. I agree.
Even if you're not thinking about it, you go to the ATM machine because you're jumping in there real quick, and it's like, oh my goodness, I haven't had any of those in a long time. So it has a lot to do with design. And that's it. Thank you for answering the question. Thank you.
No problem. So I'll jump right back into.
Sorry, I just have one more comment from Diane.
Sure.
She said many insurers do not provide coverage or sufficient coverage for dietitian, nutritionist, or chronic disease educators. Even some chronic disease programs and medical professionals blame cultural heritage food choices. How can services or research be shared more broadly and extended to others?
Yes, that's a great point. So getting coverage for dietitian services, for nutrition services, you can talk to your elected officials to promote and support the inclusion of that coverage into bills, right? Also, legislation like the Farm Bill that comes around every couple of years, that actually it allows our government and our economy to appropriate funds to certain areas, right? And if we as a population, as a nation, want more support to see dietitians or for nutrition services, for that to be covered in our insurance system, we need to tell our elected officials to put it in there, to put it in the next bill, to put it in an amendment, right? So that level of engagement is important. As far as what was the other part of the question? Research feeding back into how do we get research into?
Oh, how can services or research be shared more broadly and extended to others?
Yeah, I mean, that's a great question. So how to disseminate research findings so everybody in the community knows. One thing that's also really important to keep in mind about research is that no one study is the end all be all answer on a topic. If you think of what we know from science, each study is like a brick in a large wall that holds up what we know, right? Or what we understand, the knowledge that we've acquired. So every study, is like a brick in that wall. No one study holds up the whole body of knowledge or the body of literature, right? And so disseminating research findings is important, but when we have enough bricks in that wall that we're pretty confident on what's on top, then that's when we come up with guidelines and population recommendations, right? And so there are clinical guidelines that can be um, uh, applied in like a clinical care setting, like on an individual level, right? Based on patient characteristics. That's one type of thing. Guidelines are really, really helpful because they represent a large body of evidence. Similarly, when we have population health guidelines, like on the dietary guidelines for Americans, that's also based on a lot of individual studies that's holding up, enough of an understanding that we can build guidelines off of it. And so that's a really important, that's like the feedback loop, right? Is we have lots of individual studies that all say something, right? And then we put that together to hold up a body of understanding. And then from that, we can make more general guidelines that reflect that body of knowledge, of that body of evidence, that research. So that's a great point. All right, moving back to the services that we offer. So not only can we consult on the nutrition research design of studies, but we can also measure anthropometry and body composition. And anthropometry is just a word for measuring bodies, different ways of measuring the size and shape of human bodies to reflect the nutritional status of that body, or maybe the metabolic status of that body. Body composition is assessment is part of anthropometry, and what body composition assessment is how much fat mass and fat-free mass is in a body, right? And we can estimate that using a couple of different technologies, which I'll show you in a moment. We also do indirect calorimetry, which is a measurement of, or an estimation of resting energy expenditure by measuring the types of air that one breathes in and out, right? We can actually tell by the types of gas that one exhales what type of fuel they're burning at rest, right? So what we can tell or discern in indirect calorimetry is whether a resting person is burning mostly fat to support their energy needs, or if they're burning mostly carbohydrate to support those resting energy needs, or a mix, right? And so that can tell us about kind of what fuel is being utilized in the body. We also do staff training for multi-center trials. This is really important because for large studies that have centers or trials, have study centers all over the country at different medical centers or hospitals, it's important that all the staff at all of those centers is following the same methods and the same procedures, right? So that we can put all the data from those different sites together and interpret it and analyze it as one big study. And so we also do that. And some of our available tools are really our expert staff. We have, I'll tell you more about our staff on the next couple of slides, but we have expert staff in each of these services offered, and then some, which I'll get into. So we also have anthropometric measurement equipment, right? So this is like to measure height and weight, obviously a scale for weight, but also we have a stadiometer. That's a device that measures height that you stand next to. We can also measure, say, like waist circumference, for example, or the mid-upper arm circumference. We can also pinch the skin as an indicator of body composition. We have a couple of devices for assessing body composition. We also have the bod pod, which is this egg-shaped device behind me, which is a device where a person can sit inside of it. I'll show you pictures in a moment. And that can tell us, based on the measurements taken, of how much air is displaced by the body, how much is fat mass and how much is fat-free mass. We also have another device called a bioelectric impedance analysis, or the BIA. And what this device is about the size of a briefcase, so we can take it around to any of our clinical buildings on campus where our research patients might be. And it uses an a slight electrical signal to actually tell us what kind of tissue that electrical signal is running into. And so based on how fast that signal moves from one end to the other, say from the hand down to the foot, based on what kind of tissue it runs into, it'll change that signal. And that can tell us how much is fat mass and fat-free mass, but it also can give indication of how hydrated the subject is, like what's their water weight, as well as what's their bone mineral content and skeletal muscle mass. So a finer parsing of tissues and what kind of tissues are in that body. We also have the metabolic cart for indirect calorimetry, which I described. So if you look up here, this is a picture of our indirect calorimetry, or metabolic cart. And, excuse me. So using this mask, so a subject will wear this mask and it connects to this machine. And what it does, as I already explained a bit, is the machine assesses what is the composition of breath that's exhaled. And based on that, with a subject at rest, we can get a printout that looks like this, where on the left-hand side, it actually shows the exchanges of two different gases in the breath. And on the right-hand side, that can be translated into REE, which is the resting energy expenditure, or the number of calories that body is requires to just do metabolism and be at rest, right? All the processes that go on in the body, including, regular breathing and metabolism, keeping those cells working, right? That's the resting energy expenditure. And then we can also get an estimate of this respiratory quotient, which is an indicator of what type of fuel the body is using to support that energy demand, whether it's mostly carbohydrate, mostly fat, or a combination. Great. And in the bod pod here, as I already described a little bit, we see that we have a subject here who's sitting inside the bod pod. Subjects aren't in the bod pod very long. The door might be closed for about 50 seconds at a time, and then opened. And so here you can see the subject is also holding this tube. This is another assessment that the bod pod can do, which it allows us to measure the thoracic gas volume, or that's the air volume of the cavity that holds your lungs, the thoracic cavity.
I have a comment, or a question actually.
Yeah.
Other than research purposes, when or why would someone be referred to this type of assessment?
Other than research purposes. So for which type, the body comp or the indirect calorimetry, or either? Well, I guess. Okay.
Oh, I think she's gonna speak now. Yeah.
Yes, either.
Yeah, great. So indirect calorimetry, I'll get into that. So that tells us, that actually estimates what that person is, how many calories it takes for them to just be alive, pretty much, and be relaxed. So normally in a clinical setting, we use, and anybody can find these formulas, is we usually use formulas that predict how many calories that you need to support your life, right? You'll see this, there are a lot of nutrition apps or diet tracking apps out there where you put in your age, your height, and your weight, and your sex, and it will give you an estimate of how many calories you burn in a day. Well, sometimes we get patients, or sometimes those numbers don't seem to add up, right? Sometimes the estimated amount that a formula would tell us doesn't match how our weight is changing on such a diet, or how our tissues are changing on such a diet. So for example, if we have a formula for a specific person that says, if that person eats 2,000 calories per day, that they'll maintain a stable weight. But say that person is eating 2,000 calories per day and they're steadily losing weight, right? what this would be really interesting is to be able to discern, how many calories is that person burning at rest, and then you can use a multiplication factor to account for their extra energy burn during physical activity. And that's why this can be really helpful in a clinical context. Because also, if we think about it, formulas that are designed, they're designed to be broadly representative of a population, where any individual is going to likely be different than the estimate from the formula that pertains to the group. It might be generally accurate, but there are definitely going to be variations. And with body composition as well, say for example, we have somebody who is overweight or obese who wants to lose weight, right? Body composition assessment is so helpful in that context, because you get a picture of how much is fat mass and how much is fat-free mass, for example, before they started changing their diet or started exercising, and then you can get another repeated measurement as they've been on the program, or as they've been making these changes in their life. And it can be reinforcing to patients as well to keep up these healthful behaviors if they want to lose weight, or if they want to lose fat mass, or if they're trying to gain muscle. That's another thing that can be shown from body composition analysis. That can be really, this type of assessment can be super helpful and informative as well. Something else that the flip side of that is, so say somebody wants to lose weight, or they want to get leaner, or they want to build muscle mass. Sometimes the weight on the scale, or the number on the scale, doesn't really reflect the changes in body composition, because as somebody loses fat and gains muscle mass, you might actually see weight tick up a little bit, which could be, it can be kind of defeating or discouraging to people on a new program. And so body composition analysis can be really insightful, and especially coupled with the indirect calorimetry that tells us more about what kind of energy is being burned. We can learn a lot more about a specific individual and what's going on with their metabolism. So that's a great point. Great question. So we do have more services that we offer. That includes nutrition assessment, counseling, education, and monitoring for individuals and groups. So these are really the actions and activities of a registered dietitian in clinical care and follow-up. And this is really important, because any study that has a nutrition component, we need to be able to track it, right? What is the effect on the individual? How is it being implemented? Sometimes the intervention, for example, is counseling on, specific dietary change, or specific dietary behavior rather, and education. And we can do this for individuals or groups. And our available tools are, again, our expert staff. And I can't say enough great things about our team in the Nutrition and Metabolic Research Corps. And between all of us, we have a collective experience in research nutrition of more than 100 years. It's really unique. And so here is a picture of some of our team. We have a metabolic kitchen, where we can prepare full diets from scratch, including experimental formulas and any nutrition intervention. And so we also have nutrient analysis software, which helps us in our multi-center trials, where those centers all across the country or world might be collecting dietary intake data from the subjects in that study, and then we can coordinate and receive all those records, and then analyze those records to provide the data then back to the study. And that's actually a really important part of some of the research that we do. So in talking about the Metabolic Research Kitchen that we operate, we can prepare and serve research diets that include weighed diets, so specific amounts of food that are given at specific times. Otherwise controlled diets, so it might be a type of nutrient that's specifically controlled in the diet, as well as balanced diets. So that's balancing a nutrient that's provided in the diet with, the excretion of that nutrient, for example. So now in the last few minutes, I'd like to focus back on discussion. So kind of bringing all of this information together, and really to look for some feedback and some ideas from the group on, and the few questions I had in mind and that I'm really interested in hearing from you about are, the first one is, can you think of a nutrition related issue that affects your health or the health of your family or the health of your community? And anyone can chime in.
Sure, I can. One of the reasons I asked the question about, or made the comment about health insurers and educators, I think I've known about diabetes in my family, and we know it happens generationally, and that maybe even have a predisposition, but in the community, especially the Black community, diabetes is one of the chronic conditions that a lot of folks are pre-diabetic, diabetic at risk. But I've also observed a lot of amputations, right? Folks losing limbs and kidney dialysis. And so to me, that speaks to, I'll just put it under the umbrella of disparities of healthcare, not just behavioral. And I think folks often speak to the person and say it's the food you're eating. I like your response earlier that addressed the behavioral response, but there's also a larger issue in terms of how they're treating medical communities. So that's one of them that I think about a lot.
That is such a good point, because you're absolutely right. There are so many layers.
I'm sorry. Can I add one thing? And
Yeah.
they often don't get referred to diabetes educators. And if they do, it's just like a couple of times. But many of the programs are geared toward prevention. They're not geared toward managing the diabetes once you actually get it.
Sure. What's interesting is a lot of the prevention tips, like on dietary changes, increasing lifestyle, physical activity, those can be great for controlling diabetes. But that is a really good point that, if there aren't programs out there that, people feel like are meant for them, they might not participate in them or seek them out at all. Yeah, and that's really like an infrastructure, like a community level of, in that social determinants of health graphic that we had at the beginning. That's like, what do we experience in our communities? What resources do we have access to? What are the policies that, govern how we get resources or access resources? So yeah, including information.
And I even bump it up a bit in terms of how our medical professionals educated and socialized to treat folks. Because if I know I'm a diabetic, and I know so many times I go into places and their answer for anything is that I'm Black, that I'm a risk factor. So I know that that's what gets said to other people, or they're not getting other information that could shift them off. Or I went for years and my goal is to be off the medication. None of the doctors worked with me to make that happen.
I'm gonna move this up. Man, I mean, and that's really tough because you kind of lose faith, I would imagine, in your care providers, right? If they don't give you actionable information or even information that seems like they're really paying attention to what's going on with you, that's really tough.
But I know, like, and I have to say, especially those of us on the call, but I consider myself a very educated, involved, engaged, articulate, informed patient. So if I'm experiencing that always challenges me. What about people who aren't? What about people who just are either scared of white coats or believe that whatever they say is right? How do you challenge those beliefs? Or, and what if the answer is, oh, well, I'll just give you more medicine? So
and often from white coats it is. I'm wearing a white coat today, even though I'm a dietitian. And dietitians often do too, at least here at our hospital they do. But no, that's a great point that, if the patient comes with health concerns, or if their lab values indicate that a medication might be helpful, a lot of times the medication is suggested first before really like a comprehensive recommendation to change diet and exercise. And that really comes, I think, from the lack of access or maybe the insurance coverage to see a dietitian, to seek nutrition services. And really, you need to, behavior change is hard. It's you need to go several times to get guidance and implement these changes, and then wait to see what the fruit of those changes are, whether blood pressure reduces or weight reduces, or mobility increases or strength, right? And all of that takes a lot of time. And you're absolutely right, though, the disparities, health disparities are at every level, from the individual up to the community and everything in between. And it's yeah, that's a really good point.
I have another question and comment. Since we're on behavioral changes, behavior modification is the mother lode. Any new breakthroughs in influencing and educating that promotes sustainable behavioral changes?
My gosh, that's a huge area of research. I think there are journals that are specifically dedicated to behavior change and all of the different paths to that. And so it depends on the behavior, right? You know, what research is showing innovative, you know, techniques or something new in behavior change. Certainly, you know, at least when it comes to dietary changes, again, this is a very complex field. That's a super complex question, which is a good one, right? You know, what do we know? What are the innovations in behavior change? And really understanding how, understanding like what types of information resonate with different people, right? Some people really need to understand an idea, understand why something would work before they adopt it, right? Before they adopt any changes. Other people need to see the behavior or the change in action, and then they can get on board with it, even if they don't really understand how it works, right? Those are two examples of different approaches to being to learning and then to being able to implement change. Repetition is really important as well. Of course, this also depends, you know, what is the behavior, but we know that habits are made and can be broken and remade into better ones. We certainly know that from the research as well. And so really it comes down to practice, you know, practice what you want to become. And then you get there, right? And that can be done on individual levels or in groups and families, as well as in communities, right? Putting into practice the kind of behaviors that we want of ourselves and of our communities, and to actually put things into practice takes, at least on a community level, putting incentives in the right place, right? And increasing access to the things we want, and maybe putting more barriers up to the things we don't want, right? Convenience foods are a really good example of this. And I know we're going to wrap up here. I see that we're at the end of our time, but like convenience foods and foods at the corner store, this is a huge area of research, because, or not just research, but a huge area of public health concern, because convenient foods that are highly processed and cheap, right? They may not be good for our health, but they're convenient and they're available right there. And so what I think we need to do as communities as well as individuals is try to make it easier to make healthier choices, and to be able to make those healthier choices again and again and again, so that we can build healthier habits. And there's a lot that goes into that there. And I'm sure there are more innovations to come. But it's really having support at all the levels, the individual choice level, the group and cultural level, as well as in the community and the population, the governance level as well. That's what I think.
Yeah, there's
Great.
one more hand raised, and then I guess we'll come to our closing of the class.
Great.
Paulette?
Hello. I want to say, like, the work that I do is specifically focusing on public health and community engagement. And over the years, I've met several people from the community who've told me that their sort of very heavy weight, or you'd say obesity, was not actually due to anything that they were eating, but to the side effects of medications they were being given, specifically to treat asthma. So I've met several people on separate occasions who told me, you know, that their point was that you should not judge them, because the corticosteroids that they're given as a medication actually causes their weight gain.
Mm-hmm.
So there's that issue. So
totally. Stigma and judgment is, yeah, I'm sorry, I don't mean to interrupt. Go ahead.
So part of what I do is I try to get members of our community to understand the importance of participating in clinical trials. And in this case, with the hope that we can develop treatments that don't cause those kinds of side effects. Secondly, here in the Bronx, there are people I know who are affiliated with a movement towards a vegan diet. And so they've tried this out, so in our case at Montefiore Hospital, where we actually have cardiologists who are leading the way in showing people how their diet can drastically affect their health, and in some cases remove them off of medications. So I guess those are my 2 points, that it may not always be someone's behavior that leads to weight gain. And there are other ways that, rather than telling someone that it's because of their ethnicity, or that they are the way they are, when in fact there are other methods and other ways of handling.
Right. And that, yeah, that we can develop, through research, better treatments so that there aren't these disastrous side effects. You're absolutely right. And an individual's health, like it is a very complex picture of how is medication driving changes in these metrics, whether it's weight or body composition or anything else. You're absolutely right that, it's not always, a health condition that you can see on the outside is often not due to what we assume it's due to or whatever. And I think like just refraining from making assumptions and refraining from judging other people is really important, especially as if you're working in the community as an advocate or as a scientist, right? Is really not taking the time to pass judgment, but really let's get to the data, let's get to the information. How do these pieces fit together, and what can we do to make things better? What can we do to help this specific person improve their health, or this group meet their goals? Yeah, I agree with that, the stigma behind just stigma in our culture can just be really really discouraging for people across backgrounds and disciplines of different races and ages and across sex as well. I think, that's a really good point. Thank you so much. It's been a pleasure to connect with you all today. I thank you for your feedback and your ideas and the discussion. I really appreciate it.
Oh,
Thank you.
Something going here. Oh, wait. No, you can make a right. Can he make a right? You can make a right here.
Lula, you're not on mute.
Great.
Hello.
Hi.
Hi.
Hello. Thank you so much, Katie, for such an informative talk. I enjoyed it.
Thank you so much.
Great.
Thanks
I
for
enjoyed all the questions that came from everyone who's online today. They were great questions. Thank you so very much. Just want to remind all of the participants, please get your questions in and get your pictures for the photo novella.
Yes, it's due next week.
Thank you all.
We're waiting for all of everybody's submissions, okay?
We only got one so far.
We have a couple so far, but we are waiting on everybody else.
Oh, good.
Yeah.
But thank you again. Okay.
Thank
you, Agnes.
So much.
Now back to you.
Thank you. If there's any
thank
more
you, Katie.
questions regarding this class, please feel free to email me and I'll contact Dr. Hootman if any questions went unanswered.
Great. Thanks,
Thank
everyone.
you, everybody. Bye-bye.
Thank you.
Bye-bye.